Everyone, and thank you for joining again, Visibility Unlimited. I am doing a little bit of a different format today. I have three very special guests that I'm excited to have a conversation with, and they have impressive careers and backgrounds in the health industry. All three of them come from different points of views, but really are on the same road to really figuring out what is this with health inequities? What is this about? And each of them are making their own mark and building and trying to bridge that gap on health inequity. So I like to welcome Emily, Joe, and Latrinda. Did I say it correctly? This
You
one,
did.
yes. With me on this podcast today. So as I said, each of you have such an impressive background. Will you introduce yourself and just give a snapshot of each of your careers? We'll start with Emily and we'll go around. How about that?
Thank you, Leslie. I am Emily Green. I am one of the regional directors of operations in the private diagnostic clinics over at Duke. And I am also the president of Triangle Healthcare Executives Forum, an organization that is preparing the next generation of healthcare leaders. So I have the honor of serving in that role as well. I've been in healthcare now for over 21 years and worked in a variety of settings and inpatient, acute care settings, ambulatory. And I have come to this role of diversity and inclusion primarily because I've had to navigate the process myself. And as a Caribbean American woman, integrating into this culture and now corporate America, knowing the path that I've had to navigate and the struggles and the challenges that I've had to overcome in navigating that course has really inspired me to pursue the work of diversity inclusion and also health equity as I've become more educated and seeing my Black and Brown brothers and sisters be consumers of the healthcare system and not necessarily experience equitable care and equitable treatment. So that is my mission and purpose in why I'm here.
I love it. Thank you. Since it's Women's History Month, Joe, there's no offense. I'm going to go with the ladies and then we'll jump in.
Absolutely.
I'm going to throw that in there.
No worries.
Latrinda, please.
Yeah, so my name is Latrinda Riley. I'm currently the Director of Diversity, Equity, Inclusion for TrialCard. Just got promoted March the 1st. My background is similar to Emily. I was a medic in the Army. And by the way of some challenges I've had being an African-American woman, it landed me going from corporate to military life and thinking that would be more structured and be a little bit different, but kind of find out it's not. It's still an all boys club, the military. And so I went back to corporate and still kind of went through those challenges. So now I am taking a more firmer stance on diversity and inclusion from a leadership perspective, also from a patient perspective. I originally started in healthcare doing sales at HealthNet, doing Medicare sales, and I did a lot to the Medicare and Medicaid patients and understanding what they went through and they were able to pay for medication and trying to make their dollars kind of go a long way with healthcare. It really struck a chord with me and wanted to take a firm stance on this. That's my personal mission.
Thank you. I love it. Like I said, I am so excited to have all three of you here. Joe, tell us about yourself.
Yeah, so good morning. And first of all, thank you for having me this morning, Leslie. So I'm Alvin D'Angelo, actually go by Joe. I'm currently the Administrative Director of Ambulatory Care Operations, specifically our surgical specialty clinics over at the University Hospital. So I've been in healthcare about 13 years. I worked in a wide range of capacities, academic medical centers, federal government, state government, private, nonprofit. So a lot of different experience and background and seeing it through different lenses of healthcare. Really started diving into diversity and inclusion probably about 4 or 5 years ago. Working with our leaders over at Duke just to kind of educate our new employees on the importance of having diverse and inclusive work environments. And I have the pleasure of serving this year as one of the co-chairs for diversity and inclusion with Triangle Healthcare Executives Forum in Raleigh-Durham. So I'm really passionate about the work. I think it's something that it's a responsibility for all of us. And always felt like, I wanted to be able to use my platform and to be able to use my voice just to improve the circumstances of all of those who are kind of less fortunate.
So that's great. Into the next question of what is diversity in healthcare? What does that look like? Or does it look like from the patient point of view, from working, from the leadership? What is that? We speak about diversity all the time, but what does that look like in healthcare? Any of you can answer that and jump in.
Well, I'll start. So diversity in healthcare, we're still trying to find it. It's hard to really place a finger saying what's that percentage and what's that amount. But I will say that for diversity in healthcare, the leadership or individuals who are serving that population should look, and it should look like them that they're serving. So if there's individuals there who are non-minorities working in a hospital and they're serving more of a minority population, that really is not gonna mesh well, because the background, that culture is not, doesn't work. And so there's some layers on there. But really, for healthcare diversity, we're looking towards to figure out exactly what that looks like, what's that percentage, but we do realize there's a gap in it, and trying to figure out pinpoint exactly how to make it right and make it mesh. And that way it continues to go and evolve as years go past.
Right. Thank you. You touched on a great point about if you don't look like the community you're serving, you don't always connect with the community you're serving. So that takes me to, and we can continue with the first question, but it makes me think of the hashtag DNR Tulum, where you don't have Black doctors. Is that where it starts, the entry point? So I know I have two questions going, so you can jump in on any of them. This is a conversation.
Yeah, I think that's a good segue, Leslie, into LaTrenda's point. I think in healthcare, there's different dynamics when you start talking about diversity and inclusion. From my perspective, you have diversity and inclusion from a staff and from a leadership and from a physician type provider standpoint. What does that diversity look like in representing the patients that we serve? Making sure that the demographics that we have in leadership and the demographics that we have on our staff actively reflect our patient population. And that goes a long way, particularly when you start talking about things such as, access to healthcare and disparities and wealth gaps and things of that nature that, hopefully we'll get a chance to touch on a little bit later. So I think, one of my biggest things that I'm also passionate about is making sure that we have the adequate representation to break those barriers between providers, leaders, and patients, just to make sure that we're providing them with the best care possible.
Thank you.
Yeah, I to piggyback on that, I think diversity in healthcare, when we're looking at it right now, we are looking at the representation in our workforce and determining how that fits with the communities that we serve. And I think one of the biggest strides we can make with understanding that better is getting the data associated with that, and having some transparency in the data. I think organizations are still reluctant to release some of that information, because I don't think that we've achieved the progress that we want to see there. So there is some reluctancy to release that information. But we know that, especially in leadership positions and managerial and professional positions, that minorities and particularly Black healthcare leaders only represent about 21 to 30% of the workforce. And in the senior level and C-suite level, something like 90% of CEOs, especially in hospitals, are white. So the representation is definitely not there, and we have that global data on a national level, but on an organization specific level, I think we're still missing some of that information. And I do think it starts in the education pipeline. We are doing a way better job based on, I think, AFA statistics, which is the Association of University Programs for Healthcare Administration. They report matriculation rates of 45 to 44% for graduate programs in healthcare administration, and something like 43% for undergraduate programs. So we are getting more minorities and Black students into healthcare administration programs, but we're still not seeing those numbers when it comes to recruiting and hiring and getting those individuals into the positions where they can help affect change, help advocate for those policies for the communities that they serve. So there's a big disconnect with the communities that we serve and the people in decision-making positions who can drive positive change for these patients.
No, it's amazing to think that, and I don't know if I told you, I was actually a chaplain in the hospital at one point. So to walk the halls, to be in some of those meetings and hear the conversations, that was such a disconnect with the people that were coming in and out of the doors. With other leadership, there was very few leadership that had any color to them. And then for them to make those decisions and then to speak about the students coming in, it was rare. And I'm in Brooklyn, near Bed-Stuy. It was rare for me to see a Black young intern coming in or new resident coming in.
Right.
Let alone be a Black chaplain and serving in a hospital and female. That was a whole nother conversation that's different. But to see that was so rare. So it goes back, and I know we're going to go and pay disparity and all over, but it goes back to, if you don't see one, it's hard to believe you can be one. And if you're going to school and the loans and the amount of time and effort it takes, that pipeline there is already a heavy burden to bear on Black or brown students. And I'm not saying that folks don't have money. I think it's a heavy burden to bear on any color going into the medical field. That's a huge task. But double it up, that disconnect. Yet the stats and say, oh, we're growing. You can have all the stats you want. If you don't take the stats and take them off of somebody's desk or off someone's computer and do something about them in a real systematic way, we will continue to have a broken medical health industry. So what else can we do? Like, I know we have committees. I know, what else can we do to actually close the gap at this moment when we're in the middle of a pandemic between getting health care and communities that may not always trust the healthcare system?
Yeah, and Leslie, I think you struck a good chord. It's education. So I actually have two master's degrees. I have my MBA, I have my master's healthcare services. So I was MHA, or trying to be a CEO, CFO of a hospital. When I got out to active duty with National Guard, and I was going down that road to go ahead and start going to the hospital area and trying to go that path, they actually came back to me and said, you got to be a nurse before you become a ZEC. In order for you to do that, you gotta first start a nurse, start in an emergency room, then work your way up. And then once you get to the point that you're, 19 years of being a nurse, then you can look at becoming a CEO. And I said the same thing. Okay, but I have the education, I have the background, I have the credentials, and I even served in the military in a medical capacity where I understood medical in like bedside manner. And so from that point on, it really gave me a sour taste in my mouth in the hospital industry. And wanted to go down that path. So I switched over and went straight to a different realm, which is a healthcare organization where I supported the pharmacy industry and supported that area and aspect of operations. But I think, to Emily's point, it all starts with education. It's educating our senior leadership, educating others who are minorities, and mentoring them and mentoring individuals who are in school and saying, hey, I made it, so can you. Because there's opportunities that are there that a lot of us just don't know. We're not visible to, because we just don't see it. And some individuals don't speak, of it, because they're afraid of speaking how they got there and how well successful they are.
We need to shift that narrative, and that's what the three of you are doing right now. You're trying to shift the narrative, and that's what I love. So you can continue on this conversation, or how are you shifting the narrative? How do we get to the people to say, we have to have a voice in this? we have to be invested outside of not only our own careers, but what's happening in our community and what's happening in leadership. Can you shake it and not break it? You know?
Yeah, you know, I think good point, Leslie. I think through platforms like this, I mean, stepping outside of what we do in our normal 9 to 5 jobs each and every day, and having these dialogues and having these honest conversations. I think now more than ever, when you look at everything that happened in 2020, you know, despite everything that's happened traditionally over the past, 5 or 6 decades, when you start talking about civil rights and health inequities and things of that nature. But if we look at just what happened in 2020 and the impact that that has had from a societal standpoint, it has really forced organizations, it has really forced leaders and companies and individuals to really look at the way that not only we deliver healthcare, but the way that we treat each other. So I think, the more that we have these open and honest conversation, it sparks the light bulbs in others to say, yeah, we've been sitting on this long enough. We have set back long enough, and we've done the check the box exercises to say, oh yeah, we're really addressing disparities. Oh yeah, we're really addressing, inequities in care and lack of representation and leadership. But now, again, we're forced to really have these honest conversations and for once do something about it.
So, Emily, with you working as DI, and I know you, Latrina, as well, do you see the changes, leadership listening it with a different intent?
Yeah, I think they are listening. I think the reactivity of the community and the uproar that so many of us in healthcare have issued as a result of what happened last year in 2020 with George Floyd and Breonna. I think our health systems and our leadership had to start paying attention. So at Duke, we've done a lot of work around anti-racist training and anti-bias training. And we've developed these communities where we can create these like teaching labs where individuals are learning from each other. We're having these conversations with colleagues. The School of Medicine and our academic mission is meeting our medical mission to make sure we educate our instructors better, we educate our students better, we educate our leaders better. So we're all coming together and having these conversations that help us share this cultural and institutional framework and how we can bring it together and learn about microaggressions and implicit bias, and how do we support our colleagues in the workplace? How do we understand the challenges that they have to navigate as they come into the workforce and prepare to take care of our patients in an environment that wasn't always receptive of having we work in a healthcare setting that was once segregated, and patients were seen in different parts of the hospital. So we have a very colorful history when it comes to that, and that's still part of our narrative. So at Duke, we're very transparent about that, and we own our past, and we own what has happened in the past, and we're talking about it, and we're talking about how do we prevent the same things from occurring again. And we're allowing people to learn from each other. And what I like about, for instance, our Teaching and Leading for Equity Now series is that it cascades down from an office that was once the source of dedicated to lead this work into creating ambassadors that will infiltrate into every single unit and every single clinic and every department and create unit-based teams that can lead and drive this work. So now in my departments, in my clinic, that I oversee, we're creating initiatives around diversity inclusion for this purpose, and not just in the office that is dedicated for this work.
No, it's great. It can't sit within one office.
Yeah.
This is a cultural shift in every industry, but in the medical industry, it seems like it's a slower rollout.
Mm-hmm.
And of course, because it takes years to become a doctor or a nurse or in the field to that leadership role. I mean, I'm crazy to hear that they said you had to be a nurse. They're trying to it feels like there's always an extra barrier when it's Black or brown. Whether now to hear that in the medical field, I know it happens in corporate, but now there's always that extra hurdle. Now that you have these programs and conversations are happening, where does this community come into play with that? Like, is there a special community board that's working with D&I departments to say, here's our fear. We don't want to take vaccines, or we don't know what you're really doing. We hear these stories. Where is that connect? Or is there yet? Anyone can answer that one.
Go ahead.
I think the opportunity still lies to bridge the gap from healthcare to the community. And that's where the real bulk of the work lies. I always say that equality is not equity. And you giving folks equal access to healthcare doesn't mean that they can navigate those healthcare resources, does not mean that they can actually find the transportation to get from where they are in a rural town to our big academic institution for getting the care that they need. Does not necessarily mean that we are in network for them if they have health insurance. So equity does not equate to equality oftentimes. You know, you telling me that I can vote, for instance, doesn't mean that I have the resources to get to the voting poll, doesn't mean that I have a phone that I can call and request an absentee ballot. But you sending ballots to everyone, whether they ask for it or not, guess what? That totally assures that people are going to vote, because then they only have to ask their grandchild to make it to the mailbox and put their ballot in the mailbox. So we need to really look at that equity versus equality. And we're doing a very good job in healthcare by saying that we're providing equality for everyone. And we want everybody, we're inviting everyone to come and participate in the services that we have to offer, but we have to address the equity piece in looking at the barriers that individuals have to overcome to access the care that they need. And there are a lot of barriers. And we know that our Black and Brown patients are suffering poor health outcomes because of having to overcome these barriers. And equity is inextricably tied to quality. It's actually one of the 6 aims of quality issued by the Institute of Medicine. So we know that equity is synonymous with quality. However, achieving quality outcomes for Black and Brown patients and tying actual metrics to that still doesn't exist. And that's where we need the community piece to really come in and tell us, you know, what are the barriers to them achieving better health outcomes, and talking to those individuals. You know, oftentimes the patient that sits in front of us, we're treating a symptom of what their condition is in their living environment. So we don't always get to know what that condition is until we create that, bridge the gap between the system and the community.
So can we speak about some of the barriers that you see? I know what I've experienced or seen when I was in the hospital, and what I'm even dealing with an aunt who is older and can't navigate the web, you know, or sit, you know, they're like, oh, the elderly can just sit and hold on forever on the phone for a shot. Well, no, they can't, because they're frustrated, because they don't understand. So can you share some of the barriers?
Go ahead, Joe.
No, yeah. So, you know, I think that's a really good point, Leslie. I mean, there's been historical barriers that continue to exist. So, you know, I think COVID-19 has really highlighted a lot that a lot of those barriers still exist. So, you know, a few that I think that a lot of folks miss sometimes is, you know, barriers such as, you know, uninsured rates. So we know that, you know, African Americans compared to Caucasians of higher incomes, they're 1.5 times more likely to be insured. So we did see some progression with, you know, the Affordable Care Act of 2010 that kind of assisted those larger coverage gains, as well as kind of like a gradual design and decline in uninsured across minorities. But those gains have stalled around 2017, and we didn't see those trends continue to grow. So, you know, we still have, you know, lack of access. So when we're looking at rural health and our rural health communities and the regions of the United States, you know, a lot of folks miss that, you know, the South comprises the largest the largest makeup of minority in the US populations. And we know that the South is, racially and ethnically diverse and home to the largest people of color. But they're also home to some of the poorest outcomes that we see in health. When we reel that in and we start talking more on a local basis, we see opportunities within provider and level of care services and level of care factors such as, bias and that are both, conscious and unconscious, and lack of cultural competency, and how healthcare is organized and financed and delivered, which really truly shapes how disparities are impacted. And we have other things that we can talk about, such as the wealth gap. Let's look at the wealth gap between African Americans and other populations and other minorities, and we see that there's a huge wealth gap. I think it's something like 17 times higher for Caucasians versus African Americans. And so we can go on and on about just the different barriers that still exist today. And I think there's been a ton of work that's been done over the years, but nevertheless, we still have opportunities to drive impact.
Absolutely. LaTrinda, you wanted to add on to that?
Yeah, and Joe's spot on. And what I see, even helping patients get on therapy for drugs, is that I do see a lot of patients not being literate in healthcare, understanding their healthcare, understanding that I have other options out there because I'm underinsured and uninsured. And how do I get my drugs? And like you said before, some individuals are elderly, or some just don't know that information. And so, like our company, we actually educate those patients on that. But if they're not calling us, who's educating those patients? And who's the doctor doesn't have time to educate the patient because they have to go to the next patient, only has certain windows. But who's actually talking to patients, making sure patients are getting the drugs they need to have? During COVID, we saw a huge spike in the industry of pharmaceutical where patients were uninsured, or they could not go out to go get a refill. And so, luckily, a lot of pharmaceutical companies went ahead and did different type of programs set up. You had extensions for prescriptions until they were able to go see the providers. But a lot of providers closed down their offices and just did virtual visits, and which made it even difficult even that point in time, because now you have an elderly person who's not literate in technology and trying to talk to our doctor so they can get a refill. It was absolutely a nightmare for these patients. So I also believe, healthcare literacy is another piece and another gap that patients don't have access to, where we as healthcare providers need to go out to the community, start educating individuals. If we have to, go ahead and have seminars or community events, that's something that's needed, because right now, a lot of patients, not that they distrust healthcare, they just don't know enough about healthcare to adequately do the best thing for them.
No, I agree. I think about, I'm a big one now that uses telecommunication with my doctor, and did over COVID, and hit a button yesterday and my medicine's at CVS today and I can go pick it up or have it delivered for free. But most people don't have that. And I'm not going to say elderly. I have friends that are I may be older than you all, our age, I'm just going to throw us all in the same group here, that did not even know that their medical records, that they could put the app on their phone and start and get their results right away. So if we have younger people that are not even savvy to making appointments online and doing all of that, the gap of wealth of not being able to, not only elderly, but be in an area where there's no internet connection or shaky internet connection, or how do you download the app? Maybe CVS or Walmart is so far away, they're not doing deliveries. So yes, so we keep coming back to education. I don't know if we all notice this, whether it's education to the doctors and opportunities to students that want to become somewhere in that, be something in the work health industry, or if it's the community in regards to how do you get medicine, how do you get insurance? What is this that we're doing now? Because people are so confused. I have healthcare, I don't have healthcare. I'm in, what do you say, was it? I'm in, what is it? In circuit, in pocket, in whatever.
Out of network.
In network, out of network. I can go to the med, I can't go to the med. Like, it has become unbelievable. Mm-hmm. So we know that that's a huge part that we need to look at. education of community on telecommunication. Just what can we do? Can I go to the doctor? Can I go to the doctor? Should I go to the doctor? Should I not go to the doctor? Let's talk about the inequities of how the care culturally, not only African-American, there's our Hispanic brothers and sisters, our Asian brothers and sisters. There's a disparity across the board. Is that being addressed? The disparities of cultural communities?
Yeah, I think it is being addressed, particularly now more so than ever, with the Black community and their reservation and getting vaccines. So there is a lot of talk about vaccinating patients and getting everybody on board with the vaccination. We know that there is a high degree of distrust related to the vaccine in the African-American community because of the speed with which the vaccine was developed. Also that we know that, COVID-19 disproportionately affected African-Americans. So the fact that the virus affected us in such a higher proportion and the mortality rate was so much higher with African Americans compared to our white counterparts. Now there's this notion that this vaccine was somehow created for, Black people with the same sentiment that the Tuskegee studies were done or the fertility studies were done in North Carolina. So especially in North Carolina, there's a big degree of distrust because of the history with the fertility studies with women. There's a lot of work being done right now to get our Black clinicians and public health officials and Department of Health and Human Services experts to provide education. And we're partnering, you'll see a lot of partnerships being done with Black churches, and churches are putting on these town halls and these educational events to talk to our community about the importance of vaccination. I don't know if it's making a big difference because we're still seeing a big number of Black patients still not being vaccinated, but there is some outreach. We know that Black women have a higher mortality rate when it comes to breast cancer. Even though white women have a higher incidence of breast cancer, Black women die at a higher rate with breast cancer because of lack of breast cancer screening. That gets back to access to healthcare and healthcare resources. And that gets back to whether they have insurance that they can actually access the health system with. In the last year, the unemployment rate rose to something like 16 or 20% in the Black community. Well, we know it rose for sure. And there was always a greater proportion of unemployment in the Black community anyway to start with. And that was even more amplified with the pandemic and everyone losing jobs. So
can I jump in 1 second?
Yes.
Because so many amazing points, but I can't let that go on without saying we need to educate our community as well.
Mm-hmm.
Because we don't go to the doctor because grandma didn't go to the doctor.
Mm-hmm. Right.
Put some Vicks on it and keep it moving. Rub something, alcohol. If I hear about rubbing alcohol on something to this day, I'm like, yeah, that's not going to cure it. May clean it, but it's not going to cure it. Mm-hmm. And I think there has to be the both. We have to understand that all healthcare is not against us. Mm-hmm. And that going every 6 months and going once a year for our checkups has to be part of our culture.
Right.
Which of course we need to have the access to, as you were saying, the insurance and everything else. And I'm going to let you finish, but I really think Dr. Fauci should have started with the fact that a Black woman helped with the vaccine. I think that should have been the first rollout when we had that conversation. That's just me. Go ahead, Emily. Didn't mean to interrupt you.
I feel like that was out there, but the Black community, especially the Black community that I'm connected to, feels like that's the token person that was assigned to put that marketing out there to us. And, I've been vaccinated and I am doing my part in sharing that the vaccine is safe, that there were no adverse outcomes. I actually expected to get really, really sick with the second dose of the vaccine. And I have absolutely had no sequela, no adverse reactions. I actually feel a little bit more ickier when I get the flu vaccine, and I get the flu vaccine every year. So to have this notion that somewhat, perpetuated and being disseminated out there that something bad will happen if you get this vaccine, I think it's false. And I think it takes us sharing. But, getting back to the unemployment rate that rose in the Black community, lack of insurance also got tied to that. And I do agree that the Black community needs to be better about seeking out healthcare resources. There are clinics within health systems that are, designated for low income care. There are charity care programs. We need to get the word out there about that, because many people don't even know that they're charity programs. There are high, expensive drug companies that will have funding programs called patient assistance programs to help people get their medications, but we don't always know about that. And here's the thing, that's not always being shared with Black and Brown patients. And this is where the inequity comes in. There's a patient assistance program that when a patient is in the office, they pull out the paperwork and they give that to that patient. And that patient happens to be a white patient. And we know that when the Black patient comes in, they may not always get that paperwork. So assigning those, and we're seeing a rise in patient navigators to help patients navigate the healthcare system. Those are like social workers, but they are actually more involved in the care coordination and clinical aspect of it, and even downstream on the drug company side and outside of the hospital. So patient navigators are useful, care coordinators.
So let's stop for a second. For anyone that's listening, can you request a patient navigator?
Yes.
Yes.
So I need everyone to hear that. And if you are someone that's helping your family get through, or you are someone that has power, whether it's a corporate or medical, let your family and communities know that you can request that. Because I didn't know that. I let people know about, if you're in the hospital, request for patient relations, request for the chaplain. The more people that's in your chart, the better, but did not know about patients navigation.
Yeah, and even to Emily's point, the companies I work for, actually, I support programs that have care coordinators on there that help patients navigate to get their drug. Like Emily said, a patient assistance program, or we do the benefit investigations for the patient or provider, and then deliver the benefits to the patient, that way the patient knows what they're paying out of pocket. And any other additional foundation assistance are out there so they can get on the drug and therapy. But to your point, if no one talks about it, no one would know about it. My whole family knows about it, but they don't ever call me and say, hey, Litrin, I need help with this drug. Like, I gotta call them. Hey, did you take your medication? Let me help you with it. But you're right. It's just using your resources and know who your resources are, and educating. And I'm a huge, big component of education. I know Emily touched on the African American community, but I know the Native Indian community are being also educated as well regarding their healthcare, and because their healthcare is completely a little bit different than what we do typically offer in healthcare industry, as well as the COVID. Offering them vaccines for them and shipping things out to them. So I know that there's pockets of areas that we are communicating, but the question is that enough? Like, is that enough? Are we pouring more enough? Or do we need to give more resources and more boots on ground to educate these communities? Because I know it's going and I know it's happening, but I'm not sure. And I don't foresee, like, I'm not working in the hospital. I'm not seeing if there's actually a true outcome in our hospitals to see that's enough for patients around the areas.
And for today, that's what I'm looking for. Like that Jim on patient everything. That's the little things that I'm looking for. What can people ask for and make a difference in their own healthcare? How do they advocate even for themselves today? Go ahead, Joe.
Yeah, no, I was just going to circle back to our point earlier. I think really education is really the foundation of a lot of stuff that we're talking about today. So, let's not about our baby boomer populations, these society, we have to ask ourselves, how are we connecting with these individuals to let them know all of the different resources that are available? I think we have, just like our minority groups tend to be those that are forgotten, we have a lot of patient populations that we forget, and we just continually advance with technology and different medical therapies and things of that nature, failing to remember that, we still do have a responsibility to make sure that we are reaching out to these different communities. And, with our larger organizations, with our larger academic medical centers, larger hospitals, we have to understand that, sometimes if the patients can't come to us, we have to go to them, and the church was a good point earlier. I think Emily mentioned, there's a lot of initiatives that's being taken forward to go to places of worship, which we know are very important and very instrumental in the African American communities. We look at things such as simple, we all get in our cars every day, drive to where we want to go when we want to do it, but there's a lot of people who don't have transportation or don't have access to public transportation. So I just wanted to circle back and make sure that we're not forgetting those populations who are kind of left behind because of the rapid advancement in technologies and medical therapies and the rapid growth in healthcare that we see today electronically. So just want to circle back and make sure we're not forgetting that.
I love that. It was about 2 years ago, I had gotten a call to work on a project and it didn't happen. And it was with a large pharmaceutical company that was going to take pretty much a medical trailer, and go through pretty much 50 states. It would have been my entire life working on this project, but going with minority doctors and going into communities and setting up this trailer for 2 or 3 days. And whether they needed to bring celebrities there to get people there, tie in with other bus companies, they wanted to get as many people in the communities that could not get to medical assistance, if it was blood pressure, if it, whatever it was, making sure their medicine still matched, because some will just hold on to that medicine and don't go back and check up on it. They wanted to do across the board. And unfortunately, it was a huge undertaking, clearly, and it never really got signed off. But I think also, when we think of the African American community, we can't only think about churches. I think we need to think about supermarkets, and we need to think about malls. And I know we're not going to malls now, or we're thinking about even our child's school and that schoolyard. Where are barbershops and hair shop? We have to expand beyond where we think Black folks are going, because we have a lot of Black folks aren't going to church anymore either. So we're still missing so many, and we need to different levels. We need the older folks that may still be going to church, but we also need to reach out to their, as you said before, their grandchildren or children, so that they understand. I went into a procedure this year and I was like, okay, you're covered under my insurance. Is the anesthesiologist covered under my insurance? Like, I asked another question. What else are you charging for? What are the extra, I broke it down. But that was me educating myself to say, make sure you're asking all those extra questions and not assume everyone's under one package.
Leslie, and real quick, I think these high deductible, we need to see more reform in the area of policy. I think these high deductible insurance plan that are requiring patients to pay anywhere from $2,500 to $3,500 copay out of pocket before they can begin to get services is probably worse than having no insurance, because what you have is people saying, I don't want to get sick because I don't want to have to shell out this $3,500, or, this pain that I'm feeling here on the right side of my abdomen, I'm just going to take some Motrin for that and wait till it goes away, because I don't want to have to pay that high out-of-pocket deductible right now. And people are putting off issues where they were able to access healthcare before and go and schedule these appointments right away. And they're waiting till maybe they change an insurance plan. So it's delaying care even longer. And, oftentimes they never get out of these high deductible plans. And they have this insurance plan for emergency that if you get in a car accident, you can go to the hospital and the bulk of it will be covered. But the routine preventative care is not occurring because they don't want to have to pay these high out-of-pocket deductibles. So we really need to start, talking to our organizations and our leadership and letting them know that my parents are in this situation, and I have to help them navigate the resources so they can, get assistance for their high deductible plans. And and I'm in healthcare, and and it's challenging for me to have to help them navigate those resources that they need. So, can you imagine the patient that is not proficient in this language and not savvy in knowing where to call and who to go to? So it's a very, very precarious situation, and I do think we need to address the leadership of our organizations and the health insurance companies to give patients something that is better. They talked about Obamacare for so long, but Obamacare was getting patients the preventative care that they needed, and now we're switching and we're taking patients off the Affordable Care Act and putting them into different programs, and they can't afford those high out-of-pocket deductibles.
That's such a great point. And then we wonder why people won't go in, don't go in, and why some people are staying in jobs way too long for the simple fact that they're like, I need health care, and I have a condition, and I'm not going to be able to get new health care. And so I'm going to stay in a job where I know I don't want to be or should be, but I just need to hold on to health care.
Right.
So what's it even doing to our job market of qualified people that are supposed to be in positions that are, some of them, leadership? And now they're just saying, I need healthcare now. We're in 2021 and I'm trying to pay for my parents and this one and that one. I can't afford to go, but they're not invested where they are to even do their job, to think about changing systems or advocating for anyone else.
Yeah, Leslie, and you hit on a good point, and thank you for bringing it up to Emily, because a lot of the high deductible health plans are inexpensive. They're like maybe $20, $50 a month. And it makes sense, right? Because you're paying on it, the back end of it. But I'm a huge component of universal healthcare. And you see universal healthcare works extremely well in Canada, Australia, Italy. And you can even see the difference of how Italy rates went down because of universal healthcare in their current healthcare system compared to the United States, where everyone has accessibility to healthcare. They were able to quarantine everyone. Everyone was able to get what they needed and get the medication they needed. And that was it. And then their rates went, high and dropped down quickly. Whereas us, in our current society, we don't have universal health care. It's either you have it or you don't, or it's like the have and have nots. And if you have it, you have great health care, and you're paying for that, large large premium amount, and you're getting the good care that you should get or should receive because you're paying so much. But then we're leaving behind those individuals who just can't afford it. And then they're not going to get treated. And then, like you said, even in the employer being commercially covered, that's even a worse situation, because I can't quit my job because I have pre-existing conditions. I have cancer, or I have a heart attack, or I have high blood pressure, or whatever it is. So I do truly agree, to both of you, that healthcare is an issue throughout the United States, and going to universal healthcare will help so much to kind of negate all these other issues, and not having individuals have that fear factor of not going to a doctor, not worrying about how much you're going to pay out of pocket. So, I mean, universal healthcare, I'm a huge component of it.
I agree with you, because I had the privilege of living in Europe for 10 and a half years and was on it when I was there. And I'll never forget, I became on when I moved to Paris in France, and I was paying taxes and doing all of that and was part of that. And I could see doctors and I could see medicine, and it was everything. I never thought about it. But even living in Vienna and not being there as a performer, so not being part of the system, I remember getting sick and going into the hospital, and I'm there with my American insurance. And I'm like, I have insurance. And he was like, oh, too much paperwork. What's wrong? And he like, and in my head, I'm like, what is happening? Mm-hmm. Because, I'm in a country that doesn't really care for Black and brown folks. But this doctor was much more excited about, I had this American dancer here, and she was brought into the hospital by our rock star because I was performing with them. How did you all meet? And he was like, could care less about insurance. Like, we're going to take care of you. I walked out with medicine. Wow. Oh, you're on tour? Take this with you. We need to figure this out. Joe, did you have something you wanted to add before I went on my universal healthcare tangent?
Yeah, no, absolutely. I think all of you have touched on some really great points as it relates to kind of the complexities that we've seen for many, many years within insurance and within the way that we provide care and the cost and things of that nature. I work in an industry where we have individuals that struggle to pay a $20 copay. So when we start talking about high deductibles and really the cost of care, we still have a portion of people that can't afford the bare minimum because they're battling between, well, do I pay a $25 or $35 specialty copay, or do I get my medication, or do I get a little bit of groceries for the week? So we still have those complexities that all play out, and I think other countries, to your point earlier, Leslie, has done an amazing job, not a perfect job, but they certainly advanced the way that we look at healthcare, the way that we deliver healthcare, the way that we reimburse healthcare, all kind of focused on outcomes. And one of the last things that I'll say is that I do think we'll continue to see some movement in this area as we move from a payer structure that was traditionally largely a fee for service, and now we're transitioning to more of a preventative standpoint where we're looking at the outcomes that are based on value. So we talk about value-based purchasing and value-based outcomes, and how providers are now having to play a role in the care of their patients and being more accountable for the outcomes and the mortality of their patients that we didn't traditionally see in the 70s and the 80s and 90s. So I do think we'll continue to see some progression in this area, but it is not a quick and easy fix.
And I think value-based purchasing is where we have the potential to really focus in on and achieve the greatest change when it comes to health equity, because if it doesn't make money, it really doesn't matter. And value-based purchasing is an incentive-based program administered by CMS, the Center for Medicare and Medicaid Services, that incentivizes hospitals and providers for achieving better outcomes when it comes to certain populations of patients or patients with certain diagnoses. But what we haven't included in that bucket of incentivized payments yet is patients, Black patients, and marginalized groups who achieve poorer health outcomes. So the minute we start attaching a monetary component to seeing improved health outcomes for patients that are marginalized and vulnerable patients, then we can potentially start holding our providers and our healthcare providers more accountable to making sure these patients achieve the quality outcomes that their white counterparts are receiving. So we have a huge opportunity in challenging, and this goes back to my whole platform about advocacy and talking to our insurance companies and talking to the Joint Commission, those regulatory bodies that hold us accountable to a certain standard. When those bodies get involved, we as healthcare leaders have to start putting in place protocols and programs and procedures to make sure we attain that metric, because then we start losing money if we don't meet those targets, or if our patients certainly start being readmitted to the hospital in 30 days, we're penalized for that. But we have not looked at the percentage of Black patients and brown patients that are readmitted within 30 days. And when we start filtering out that and parsing that group out and having the Joint Commission and CMS start putting standards in place for that, I think we'll start seeing some greater results in our hospitals.
That is great. Thank you for that. I know we're almost near the end of our time, but I wanted to give each of you a moment to, if you wanted to add something else to recap, or something that you really want to leave with people to understand what's happening as we all try to figure out what is happening in our healthcare system. Anyone add a last minute thought?
Yeah, I think forums like this need to continue. I think we need to keep the conversation going. The minute we stop meeting about this and we stop talking about it, we take our eye off the mark. And my biggest fear is that we get to a point of comfort not stability, not progress, but comfort, where we stop seeing the media outpouring of support for this. We stop seeing the public outrage. We stop seeing the riots, and then we think that now it's gone away. So I don't want to see us get to a place that it's so comfortable. So the more that we schedule talk like this, the more that we continue our courageous conversations, the more that we get these affinity groups together and develop action plans. I would say meet and talk, but then set a goal, set an action plan. Like, let's figure out how we can talk to the insurance companies. Let's figure out how we can engage our senior leadership in this. Let's figure out how we can talk to Medicare and Medicaid services about this. So the policy and the advocacy portion is huge. And when we're at this level, getting to that level is a little bit harder to navigate, but there are organizations like the Agency for Healthcare Equity that are doing it well. Cook County hospital in Chicago now has a housing director and a housing coordinator, because they are looking at those social determinants of health. We have to understand that racism is a public health crisis, and we are in the business of healing people, addressing their sickness, and not causing harm. And in order for us to really be committed to not causing harm, we have to look at what's causing harm in their personal lives too.
Emily, you wrap that up. Anyone else would like to add before I wrap that up? Cause no harm. We are supposed to be healing. Trying to close it out. Yes.
One thing I just say is educate, educate, educate. In addition to what Emily's saying, education is the key in educating ourselves and educating the communities. And we'll go so far and so beyond all this. But in addition to what Emily's saying, education is really the key. Short and sweet.
Yeah.
Love it. Joe?
Yeah, absolutely. And to both of you guys' point, one of the things that I want to make sure that we don't get lost in is yes, continue to educate. Yes, continue to have these dialogues, continue to educate the masses, but also being very intentional on how we move to action. So I think a lot of times whenever we talk about societal issues or healthcare inequities or things of that nature, we get lost in the conversation. And the action over the next year, over the next 3 to 5 years, kind of gets lost in translation. So just making sure that, yes, we're not only still having these important conversations and we're advocating and we're providing services for people and minorities or those who are less fortunate, but also making sure that we're being actively progressive in that action.
Thank you. I am so excited that we had, I hope, the first of many conversations, Emily, Latrina, and Joe. So for those that are listening, we're going to say it again: education, accountability, leadership, cultural statistics, action, plan, take intent into action, and do no harm, because we are here to be of service of each other. Do no harm. Thank you.
Thank you.
I really hope this is part 1.
Thank you for having us.
Thank you for having us.
Absolutely.